Good evening. My name is Sarah Saberi. I am co-director of the Cardiomyopathy program at University of Michigan, and I'm thrilled to welcome you all to this evening's program, New Paradigms in Hypertrophic Cardiomyopathy Care Gameshow Challenge. We're going to be specifically focusing on cardiac myosin inhibition tonight. I am joined by Drs. Gregory Lewis, professor of medicine at the Harvard Medical School, and Dr. Marty Marin, who's the director of the Hypertrophic Cardiomyopathy Center at Lahey Hospital and Medical Center. So we are going to be divided into teams and competing with each other in order to kind of get a conversation going. The game is going to be consisting of 3 rounds. The first one is focusing on where are we in 2024 in terms of hypertrophic cardiomyopathy care. The second round is focused on clinical updates in hypertrophic cardiomyopathy pearls for cardiology practice. And the last round is going to be case consults, and we'll be presenting real cases of patients that we have been seeing and taking care of, and integrating some of the approaches to care. And then at the very end, there'll be a discussion panel and a Q&A session that we'll all be able to participate in as well. So these are 3 teams: the Heartbeat Heroes, the Pulse Protectors, and the Cardio Crusaders. One other thing to mention is that there will be a backstage pass that you can join us in at the end of the session if there are still questions that you have or issues that you want to talk about with the 3 of us. We'll be happy to join you at the very end. Okay, so round 1, where are we in 2024? Our first category is going to be physiology and pathophysiology. Then we'll move into exercise capacity and finally into management challenges. So we're going to start off with the first category, physiology and pathophysiology. And we're going to start with a question just to see what you guys think. So the question is, what is the primary underlying pathological process leading to hypertrophic cardiomyopathy? And the answer choices are 1, myocyte hypertrophy, 2, myocyte disarray, 3, impaired actomyosin cross-bridge cycling, 4, interstitial fibrosis, and 5, increased potassium sensitivity of myofibril ATPase activity. So go ahead and enter what you think the correct answer is. And we'll have a virtual drum roll, and then the answers. So about 42% of the participants tonight chose the correct answer, which is that HCM's underlying pathologic process is kicked off by impaired actomyosin cross-bridge cycling, which actually then leads to all these other processes that you see in the other answer choices, which include myocyte hypertrophy, disarray, interstitial fibrosis, and increased potassium sensitivity. So let's get started here. It's taken quite a bit of work for us to have some understanding of what is happening in the pathology underlying HCM. So in this picture, and don't let your eyes start glazing over when you're seeing kind of biochemical pictures and processes. I'm going to break it down for you. The myosin is in the green here, and basically what we know happens is that each of the myosin heads binds and hydrolyzes ATP into ADP and an inorganic phosphate. And that is followed by a non-force-bearing weak interaction with actin, which is in the gray. And some of these isomerize to strong binding, force-generating cross bridges that are associated with the release of the inorganic phosphate and a power stroke, which is indicated in the dotted arrow, that involves a rotation of the myosin lever arm, followed by a release of the ADP. And so now then a new ATP molecule binds to that myosin, leading to a detachment from the actin and a subsequent reversal of the lever arm. There's three hypotheses in terms of kind of what the molecular underpinnings of HCM are. And these are not mutually exclusive, and we haven't figured out which exactly of these or which combination of these things may be going on. So the first is that HCM genetic mutations can alter the kinetics of the individual steps independent of any loading considerations. And that then results in an increase in the myosin population in the strongly bound state. Another hypothesis is that HCM causing mutations in the myosin could affect the load dependence of the contractility, such that then ADP release rate of the cardiac myosin is slowed by load on the sarcomere. The mutations that further impede that release of ADP under load could prolong the lifetime of the myosin heads in their strong actin binding state, and that then in turn could lead to hypercontractility and impaired relaxation. And the last hypothesis is that myosin mutations could actually just increase the number of myosin heads that are in that strongly bound state by freeing the myosin heads from their sequestered off state, which is thought to comprise about 50 to 60% of the total myosin heads in the healthy cardiac sarcomere. And that this is actually emerging as the most common method by which HCM mutations cause hypercontractility. What we've seen in basic science studies is that during relaxation, the head domains of the paired myosin molecules engage via an interacting heads motif and assume either a super relaxed state, which is the SRX denotation here, in which both the ATP binding domains are kind of inhibited and unable to bind with actin, or a disordered DRX conformation in which only one myosin head is available to hydrolyze ATP and interact with actin. The proportion of myosin molecules in the two conformations really provides a fundamental mechanism for enabling efficient myocardial performance and conservation of energy. And a majority of the myosins exist in that DRX state in a normally functioning myocardium. So HCM mutations really disrupt that physiological balance of myosins in the SRX versus the DRX formations, and therefore you get this kind of shift towards the DRX and hypercontractility, abnormal relaxation, and metabolism. We're going to move on to exercise capacity, and that's going to be led by Dr. Lewis.
Okay, thank you, Dr. Sabari. Really excited to be here with you tonight, and we're going to take a deep dive into exercise capacity in hypertrophic cardiomyopathy. So we'll start with a question. Which of the following statements is correct? Patients with hypertrophic cardiomyopathy have compensatory enhanced ventilatory efficiency during exercise. In patients with obstructive HCM, exercise limitation arises exclusively from outflow tract obstruction. Third is New York Heart Association Class 1 does not rule out significant limitations in measured exercise capacity in HCM. Fourth, maximum exercise testing should generally be avoided in patients with HCM due to safety concerns. And then fifth, none of the above. Give you a chance to respond to these questions, and then we'll delve into some more information. All right, so not dissimilar to Dr. Sabari's question, a little bit less than half of you got the correct answer, which is great in terms of what we're going to go through for content. But this question is really intended to focus our attention on the fact that ascertaining New York Heart Association class, including hearing from patients that they have no limitations, does not mean that objective measures of exercise capacity will also be normal in these individuals. And it turns out patients with HCM have less efficient ventilation, so they have inefficient ventilation during exercise. Their exercise limitation arises from mechanisms beyond outflow tract obstruction. We know that we can conduct maximum exercise testing safely in the HCM population. And so let's delve into the additional slides. So in terms of mechanisms that contribute to exercise intolerance, I think the concept that an outflow tract obstruction contributes to limited cardiac output and to exercise intolerance is something that's well understood. But the purpose of this figure is to highlight the multiple mechanisms by which cardiac reserve is impaired and manifest during exercise in patients with HCM. We know that there's outflow tract obstruction. There's also hypertrophy, mitral regurgitation, small vessel disease that can lead to ischemia during exercise, significant diastolic dysfunction, fibrosis, leading to adverse cardiac remodeling, secondary pulmonary hypertension, myocardial ischemia. And all of these mechanisms can co-conspire to reduce exercise capacity, to decrease cardiac power. Chronotropic incompetence is also common in these patients, which of course is unrelated to outflow tract obstruction. And then, as I mentioned in the previous slide, inefficient ventilation, meaning that these patients have to breathe more to eliminate a normal amount of CO2 during incremental exercise. And if we look at the metabolic costs of various activities relative to what patients with hypertrophic cardiomyopathy can afford, this diagram is actually adapted from a study in heart failure preserved ejection fraction, but similar principles apply in HCM. You can plot what an average patient with HCM can afford, if you will, which is somewhere in the range on average of about 18 milliliters of oxygen per kilogram per minute. And then we can look at what various activities cost in terms of their oxygen uptake to perform them. So at rest, all of us that are on this presentation tonight are utilizing about 3.5 milliliters of oxygen per kilogram per minute. But if we just go to doing something like household chores or walking 3 miles per hour, that comes at a much higher metabolic cost, about 3 times that of rest. And you can see that's getting up into about 3/4 of what these patients can afford. Things like carrying groceries or certainly jogging 5 miles per hour is way out of bounds for these patients in terms of coming at a metabolic cost that's beyond what they can afford. And so exercise tolerance is significantly impaired in HCM, and it has significant impact on what these patients can and can't do on a daily basis. If we think about how we go about measuring exercise capacity during clinical care of patients with HCM, there's a variety of tools at our disposal. Perhaps most commonly used is New York Heart Association classification. We can also do scores like Kansas City Cardiomyopathy questionnaires, 6-minute walk tests, or short battery physical performance testing. We can look at patients' wearable devices now and their actigraphy, or we can perform cardiopulmonary exercise testing to measure an array of variables. And this is a busy slide, but I want to highlight the fact that there's trade-offs between these different measurements. While the New York Heart Association classification certainly comes at a low cost and ease of administration in terms of what we document in the records of these patients, I've already highlighted the fact that oftentimes patients can be New York Heart Association Class 1 and in some cases have profound objectively measured exercise capacity. And even if somebody is New York Heart Association Class 2 or Class 3, that doesn't necessarily mean that it's their disease of HCM or the disease severity that's mediating their limitations in exercise capacity, because there's really not cardiospecificity to New York Heart Association class. It doesn't capture volitional effort, nor does a 6-minute walk test, and it isn't particularly prognostic for these patients. So I think it's important to think about going beyond just NYHA, going beyond 6-minute walk tests, and thinking about more objective measures that capture volitional effort of our patients, various intensity of exercise, and predicts prognosis in these patients. And that's one of the reasons that I want to emphasize some of what we've learned from the application of cardiopulmonary exercise testing to patients with HCM. You can see clinically meaningful change down here at the bottom in terms of the degree to which we think a change in each of these parameters is meaningful. Certainly 1 New York Heart Association class, 5 points on the KCCQ, somewhere in the order of 20 to 30 meters on 6-minute walk. And we'll talk some more about a 1 ml per kilo per minute increment in peak VO2. And so the cardiopulmonary exercise test captures the metabolic response to all of exercise. It's not just peak VO2. When we perform one of these tests, we're actually measuring metabolic rate at rest. We're measuring metabolic rate during the initiation of exercise, during low-level physical activity, intermediate physical activity, up until the anaerobic threshold and beyond, and then, of course, peak exercise capacity and into recovery from exercise. And so we can account for how much volitional effort was expended based on the assessment of the respiratory exchange ratio. We have cardiospecificity in terms of our electrocardiogram and our blood pressure assessments and our gas exchange measurements. And we know that we get more potent prediction of outcomes than we see with a 6-minute walk test or New York Heart Association class, high levels of reproducibility, and little in the way of training effects. There are some limitations. The cardiopulmonary exercise testing is not readily available at all institutions. There is a need to develop some expertise in terms of the interpretation of these studies, though they're becoming simpler and simpler to perform. And the cost of them, of course, is in excess of what it costs to do a 6-minute walk test, for example, but it's similar to the cost of performing an echocardiogram. So if we think about some of the parameters that have been associated with outcomes in patients with HCM, Carolyn Coates had a very nice study a number of years ago in which she and colleagues demonstrated that the hazard ratio for every 1 milliliter of oxygen per kilogram per minute increase was 0.82 for a population of patients with HCM. She also found that the VE/VCO2 slope or ventilatory efficiency was predictive of outcomes. Masri and colleagues have looked at age and gender predicted peak VO2 as a predictor of outcomes. Other studies have looked at this ratio of VE/VCO2 or slope of VE/VCO2 throughout exercise. If we integrate both VO2 and blood pressure responses, we know that the VO2 blood pressure product is predictive of outcomes in this population, and a higher circulatory power is associated with better outcomes. And so we are accumulating more and more data that closely ties how somebody performs during a cardiopulmonary exercise test with what their long-term and intermediate outcomes will be. And finally, if we look at the 2024 HCM guidelines, you can see that the role of exercise in exercise stress testing is increasingly emphasized in patients that have non-obstructive HCM and that are getting into advanced stages of heart failure. We know that cardiopulmonary exercise testing is a requisite part of evaluating somebody for consideration of heart transplantation, and that has a class recommendation 1. For performance of CPET with advanced disease in HCM. In patients that have HCM, based on the information I just presented, the cardiopulmonary exercise testing can be helpful for establishing prognosis. And then in patients that have obstructive HCM with ambiguous functional capacity, getting that exercise stress test can give us objective information to help guide therapy. I'll turn it over to Dr. Marin.
Yeah, thanks, Greg. Appreciate that. All right. Let me see. Okay. So as we've done in the last 2 rounds, I'm going to start with a question. What complication of HCM is responsible for the highest mortality today? Number 1, heart failure due to obstructive HCM, heart failure due to non-obstructive HCM, sudden cardiac death, or embolic stroke from atrial fibrillation. Okay, so actually a little over a quarter of you thought it was heart failure due to obstructive HCM, and 40% of you, the majority, actually thought it was due, the correct answer was sudden cardiac death. Actually, the correct answer here is heart failure due to non-obstructive HCM. So let's talk a little bit more about that. Okay, so we're limited a little bit with time here, but essentially, we've developed a pretty robust risk stratification strategy for hypertrophic cardiomyopathy in the last couple of decades that can identify reliably those patients that are at highest risk for sudden death. We don't have time to go over all of that because this is mostly focused on this seminar is mostly focused on treatments related to myosin inhibitors, but this algorithm and strategy for sudden death has really lowered the sudden death incident in HCM over the last several decades, along with, of course, the ability to do that with the ICD. And with that, it's has seen an increase actually of heart failure, and oops. Okay, sorry, the advancing is a little bit hard. So the data to support that is here, showing you kind of a large single center, several decade follow-up study in patients with hypertrophic cardiomyopathy from our colleagues in Italy. And you can just see that sort of looking at HCM related mortality over several decades of time from the initial evaluation and diagnosis, you can see that HCM mortality increases over time. And what's driving that mortality today is the progression to end-stage heart failure from non-obstructive HCM. And so let me just kind of give you a little sense of what that means. Here's another study showing you a large cohort of patients with non-obstructive HCM. Again, we define non-obstructive HCM as the absence of SAM septal contact, generating alpha gradients either at rest or with provocation. That defines a non-obstructive patient, so gradients less than 30 millimeters of mercury at rest or with provocation. And if you look at patients with non-obstructive HCM that are asymptomatic or mildly symptomatic, and you follow them for a fairly long period of time, a small cohort, about 10%, will develop end-stage heart failure, okay, from diastolic dysfunction, impaired relaxation, and will be candidates for advanced heart failure therapies like transplant, et cetera. Of these that develop the end-stage heart failure, about half of those HCM patients have what we call preserved systolic function, EFs of greater than 50%, and about half of them will have ejection fractions of less than 50%. And so this rate of progression of developing progressive heart failure in the non-obstructive group is about 1.6% per year. So relatively lower than other groups, but the point is that we don't really have today effective therapies to either prevent the progression of heart failure in the non-obstructive groups to class 3 or 4, nor do we have really great therapies to improve the symptom burden in the non-obstructive patients that, for example, are class 2 or 3. We use beta blockers, we use calcium channel blockers to try to improve LV filling and therefore improve the symptom burden, but those are often suboptimal in their efficacy or they're associated with side effects. And so this really represents perhaps the greatest unmet treatment need in hypertrophic cardiomyopathy today is the symptomatic non-obstructive HCM group in which progressive heart failure is driven by diastolic dysfunction, impaired relaxation, and a decrease in stroke volume with exercise. And I'll just make the point that for those patients with non-obstructive HCM that develop end-stage heart failure, again, about half of them develop this systolic dysfunction where the EF drops below 50%. In this group of patients, that kind of progressive adverse left ventricular remodeling, where you get impairment in systolic function and other adverse remodeling of cavity dilatation and wall thinning, is really driven by a process of myocardial fibrosis. You can see here the MRI showing you uptake of gadolinium, extensive scar throughout the LV cavity in this patient who had ultimately underwent transplant, and the explanted heart you can see stained here in blue, that those areas of replacement fibrosis. And so really, we need additional agents that can modify this kind of process of fibrosis and adverse remodeling to help benefit this subgroup of patients with HCM that develop end-stage heart failure due to systolic dysfunction. So I'll also just take 1 minute to mention, another area I was asked to also talk about, the area of unmet need in the obstructive population of patients. And, showing you here an echocardiogram where there's mitral valve septal contact, impedance to LV outflow, the generation of a pressure gradient. This is the mechanism of subaortic obstruction in HCM, in which these high LV pressures from the actual mechanical impedance due to the mitral valve creates progressive heart failure. And in one of the areas that we see now are those patients, for example, that are asymptomatic with high gradients, who we often wonder, what should we be doing for those patients to potentially alter their natural history? It's obviously tough to take a patient like this to the operating room or alcohol ablation if they're asymptomatic. That's not indicated because of the risk of those procedures, but you have to wonder about the long-term implications of high LV pressures here. And now we have the opportunity to consider, this is the consideration, this is all speculation a little bit right now because this has not yet been proven, but I'm showing you one of the areas in which we're moving in HCM is potentially the use more upstream of cardiac myosin inhibitors, which have high benefit in lowering gradients and normalizing LV pressures, and the opportunity to potentially improve natural history, particularly maybe in this challenging subgroup of patients who are asymptomatic with high gradients. And so let me just sort of show you a little bit more about what I mean. And this is sort of a schematic showing you at any one point in time, about half the patients with obstructive HCM are asymptomatic, about half have class 2 symptoms, and about 5% are class 3 or 4. And again, as patients progress with obstructive HCM to class 2 or 3 or 4, they also suffer from the same adverse remodeling that I showed you in the non-obstructives, often with fibrosis. It results in left atrial remodeling and diastolic dysfunction as well. And so the cardiac myosin inhibitors, we're going to talk more about this as well as we go along in the seminar here, but cardiac myosin inhibitors have been shown to have benefit in reducing symptoms in those patients with obstructive HCM, they're class 2 and 3. And so this is indicated right now to improve the symptom burden in those patients. But perhaps in the future, as we move forward, we will consider, with evidence to support it, of course, the possibility that we will be moving upstream with some of these treatments to help potentially alter natural history for these patients, both by hopefully preventing progressive heart failure in terms of symptom burden, but also helping prevent remodeling, adverse remodeling in the form of structural changes that occur over time in these patients as well.
Okay, Heartbeat Heroes is coming out of the gate strong. We are going to move on to round 2, where the rest of us will be able to redeem ourselves. This is going to be a section focusing on clinical updates in HCM, pearls for cardiology practice. And we're going to start with disease-specific therapies and then move into cardiac myosin inhibitors and outcomes optimization. So we'll start this section off again with disease-specific therapies and a question related to it. Up until recently, all of the following have received class 1 or strong recommendations for treatment of symptomatic obstructive HCM, except 1, non-vasodilating beta blockers, 2, non-dihydropyridine calcium channel blockers, 3, angiotensin receptor blockers, 4, disopyramide, and 5, septal reduction therapies. Go ahead and put in which of these choices is not a class 1 indication for treatment of obstructive HCM. You got it. So the 44% who said that angiotensin receptor blockers do not receive a class 1 strong indication for treatment of symptomatic obstructive HCM are correct. The rest of these options actually do have historically had class 1 recommendations in the American College of Cardiology, American Heart Association guidelines for the management of hypertrophic cardiomyopathy for treatment specifically of obstructive HCM. So historically, the recommendations have been to start the treatment of obstructive HCM patients who have symptoms with non-vasodilating beta blockers. And that if there's not adequate symptom response, then you can either add or replace the beta blocker with verapamil or diltiazem. Can think about adding disopyramide, diuretics sparingly if needed, for management of congestive symptoms, and then ultimately moving to septal reduction therapy. So I think it's important for us to kind of look and see what is the strength of the data behind those recommendations. And I was actually pretty surprised to find out what the data had been. So this is a study that is cited in the 2020 guidelines for the data that supports use of beta blockers as a standard of care pharmacotherapy for patients with symptomatic obstructive HCM. This is data from 7 patients with what at that time was termed idiopathic hypertrophic subaortic stenosis, who had angina, 6 males, 1 female, and they were treated with propranolol ranging in dose from 80 to 480 milligrams in 4 divided doses daily. And the article states in the methods section that they were treated for, quote, several days, followed by several days of placebo, with 1 full day elapsed after each crossover before treadmill exercise. And it's mind-boggling to think that something like that would be, you know, that kind of methods would be allowed in this day and age of clinical trial design and operations. But what you can see is that there was an improvement in exercise time with propranolol treatment in the graph on the left, and as compared with those who were treated with placebo. And in the graph on the right, those patients who were treated with placebo are marked with squares, and those with propranolol are marked with circles. And you can see that the lines that have the circles show that it took, where patients were treated with propranolol, it took longer for them to develop angina when treated with propranolol than those patients who were treated with placebo. So that was the original kind of strength of evidence to support beta blocker use. That's followed by this study that was looking at the evidence for treating patients with verapamil, and it was 19 patients with HCM, 17 of whom had resting or provocable outflow obstruction with gradients of at least 30 millimeters of mercury. 15 of them had been on propranolol prior to starting on this trial, and 4 of them had previously tried propranolol but had had either intolerances or no significant symptom improvement, so were no longer on propranolol at the time that they started this study. These patients then underwent an inpatient hospitalization where they had a 2-day washout of their cardiac medications, and then either were treated with verapamil 80 or 120 milligrams, propranolol 40 or 80 milligrams, or placebo every 6 hours for 5 days. And they underwent surveys about their symptoms and underwent exercise testing. And what you can see in table 2 here on the left was that those patients who were treated with both verapamil and propranolol felt that they had more of an improvement in their symptoms. They felt, and they had more of an improvement in their exercise capacity with both on board rather than one or the other. And on the right is actually a graph of 15 of the patients who were discharged from the hospital on verapamil. 120 milligrams every 6 hours. And 8 of them had repeat exercise testing about 4 to 6 months after their discharge. And you can see that there's an average long-term improvement in exercise duration. So you can see what the exercise duration was when they had been treated with placebo. Early verapamil is what their exercise time was at the end of their hospital stay. And then late verapamil was the exercise study about 4 to 6 months later. And you can see that there was an improvement in the exercise time and that it was sustained over 6 months. But this is really the strength of the data behind our guideline recommendations. Septal reduction therapy, of course, includes surgical myectomy, where when the most thickened portion of the heart is in the basal septum, a surgeon can go in through the aorta and make a slice to kind of open up that outflow tract and debulk that thickened septum. And then I'll call septal ablation, where if the coronary anatomy is amenable, then you could squirt some alcohol into a septal perforator and basically create an ischemic region that causes scarring back of the myocardium. And that you can see that there is improvement in survival free from HCM-related death in those patients that undergo myectomy. This is what's represented in the top right graph, as opposed to patients with obstructive HCM who do not undergo surgical myectomy. And that with septal reduction therapy, that there are, there's improvement in terms of death and complications as well. The molecular underpinnings of the hypercontractility have now started to become a therapeutic target, and Dr. Marin will speak more to us about this, but some of the data that I had shown you before lends itself to drug therapy. If we know what the underlying problem is, we can attack that. And the first of the agents that was discovered to be able to deal with this was MYK-461, which now we know as mavacamten or Camzyos. And you can see that when HCM patients are sarcomere, are treated with mavacamten in the dashed line in the red graph on the bottom, that you see a reduction in the sarcomere shortening back towards what is normal. So Dr. Marin will now take us into the current state of clinical trials involving cardiac myosin inhibitors.
Thanks, Sarah. Okay, again, we're going to start with a question. Aficamten and mavacamten, both of those are cardiac myosin inhibitors. Mavacamten is the first approved one. Aficamten is still under investigation as a next in class. Are drugs in which class? I already said this. In which class? 1 beta blocker, 2 calcium channel blockers, 3 SGLT2 inhibitors, or 4 cardiac myosin inhibitors? Yep. Okay. So the guy inadvertently gave that away. So sorry about that. But yes, 92% are correct. Both of those are cardiac myosin inhibitors. So let's again take a little bit of a deeper dive into this class of drugs for hypertrophic cardiomyopathy. You could see over the last several years, there's been numerous clinical trials evaluating the efficacy of both mavacamten and aficamten in symptomatic obstructive HCM, and now ongoing clinical trials for both of these drugs in symptomatic non-obstructive HCM as well. So the story really perhaps in some ways begins with mavacamten and the phase 3 Explorer HCM trial published a few years ago, where symptomatic obstructive HCM patients, again, those with gradients of 50 millimeters of mercury or more, class 2 or 3, randomized to mavacamten or placebo for 28 weeks with a primary endpoint of improvement in how patients function as measured by peak VO2, as Greg had kind of took us through earlier, as well as improvements in symptoms or greater improvements in functional class by peak VO2 without any change in NYHA class, which was achieved in about a third of patients on mavacamten in the Explorer trial, which was significantly greater than that achieved in those on placebo. And you can see also the individual changes in both NYHA class and KCCQ questionnaire as well. Okay, and so what's driving, what was driving that improvement in both functional capacity and symptoms with mavacamten? Well, the most important probably in a way is the reduction in gradients, alpha tract gradients associated with this treatment. Again, these class of drugs modulate contractility, and by modulating contractility, you have a very profound effect on lowering, and in many cases abolishing, outflow tract gradients, both at rest, as you can see on the left here with mavacamten, and with provocation, shown here on the right with mavacamten, again in blue, and the placebo arm in the Explorer trial in red. So significant decreases in gradient, which come at a small cost of slight decreases, I should say, in systolic function or ejection fraction because of that effect of the drug on contractility affecting ejection fraction. And you can see small decreases in ejection fraction over the treatment period in the Explorer trial with mavacamten compared to placebo. Now, if we look at other issues related to safety with mavacamten, adverse events shown at the top of the slide, pretty balanced between mavacamten and placebo, and a very small, less than 1% of patients needed to discontinue treatment permanently because of adverse events. Now, if we look at our sort of safety bar, so to speak, for systolic dysfunction related to this class of drugs, that bar has been set at an ejection fraction of less than 50%. And if we look at the incidence of low EF with that bar in the Explorer trial, it occurred in about 6% of patients on mavacamten and less on placebo. For those that had low EF events, about half of them were asymptomatic with that low EF event, and half of them had symptoms of heart failure. And importantly, of those 7 patients on mavacamten with low EF events, there was the need for dose or drug interruption. And when that occurred, in follow-up, essentially ejection fraction returns back to baseline. Okay, so that the principle here is that systolic function is reversible with the myosin inhibitor therapies following dose interruption. Okay, there were no new adverse reactions in follow-up phase 3 trial. We'll talk about Valor HCM in a minute, although with Valor, there was a greater incidence of low ejection fraction than that seen in the initial Explorer trial, upwards of about 12% of patients actually with longer exposure to mavacamten had ejection fractions that were less than 50%. Okay, so if we look at longer-term efficacy of mavacamten, that would be the Explorer LTE study showing you here out to almost 120 weeks. So if we look at out 120 weeks of drug exposure to mavacamten, you see that almost 66% of patients essentially have an improvement and a continued improvement in symptom burden by 1 NYHA class, and 10% improving by 2 NYHA classes, and about 23% or so with no change in NYHA class out to 120 weeks. So essentially, what we're seeing is as we move out of the shorter phase 3 studies and getting a better sense of longer-term exposure to mavacamten, we're seeing maintain a benefit in terms of symptom relief in an important subset of patients, almost 2/3. Now, this is the Valor HCM study, which had definitely about 3 different publications associated with it at different time points. But essentially what it was showing or trying to demonstrate was the important principle that I just showed you, that mavacamten improves both symptom burden and reduction in gradient. So if you got an improvement in both of those, you're going to have an effect on whether patients with obstructive HCM are eligible for septal reduction therapy like surgery or ablation, which is based on the eligibility for those, based on symptoms of NYHA class 3 or 4 with outflow gradients of 50 millimeters of mercury or more. And so what the Valor HCM showed you was that in the majority of patients that get put on mavacamten, over time, because they've got an improvement in both symptoms and gradient, they become essentially ineligible, the vast majority of them, 82%, for septal reduction therapy. Okay, they become essentially too good in a way for those procedures, for those procedures to be necessary, versus about 18% on mavacamten who remained eligible despite that drug therapy for SRT. So again, showing you here that the opportunity really with myosin inhibitor therapy to take patients and make and delay or potentially prevent or eliminate maybe even the need for invasive treatments for relief of outflow tract obstruction, at least in the vast majority of patients that go on these drugs, at least at this time point. Okay, so if you look at mavacamten indications and warnings, so to speak, it's indicated, the indication or labeling for mavacamten is adults with symptomatic obstructive HCM class 2 or 3. Again, it can, mavacamten, in terms of precautions, it can cause systolic dysfunction. We talked about that. Therefore, is the need for patients to agree to be or participate in what is a risk mitigation program called REMS, in which they commit to longitudinal monitoring with echocardiograms to ensure that the ejection fraction stays in a safe range and that dose adjustments can be made to achieve that goal. There can also be drug-drug interactions as well, and embryo-fetal toxicity and the need for contraception use if you are on mavacamten. Okay, so mavacamten is FDA approved as well as approved in other parts of the world as well for, as I said, symptomatic obstructive HCM. Moving now to next in class myosin inhibitor, aficamten. How does that differ? Let's talk about that in terms of both efficacy, safety, and ease of use. So aficamten was designed really to leverage certain pharmacologic properties and leverage these for safety and efficacy. And to start that conversation, aficamten, again, next in class myosin inhibitor, works mechanistically in a very similar way as mavacamten. It decreases the interaction of the myosin-actin filaments at the level of the cardiac sarcomere, again, modulating contractility to have an effect on gradients. And its pharmacology is it has a shorter half-life, so it has the opportunity there for more rapid dose adjustments, in fact, every 2 weeks, to achieve relatively rapid clinical efficacy because of that, and also rapid reversibility as well, which is favorable in terms of safety. It has a wide therapeutic window, which just means that as the dose of aficamten is increased, you see relatively small changes in ejection fraction, which allows the opportunity for more individualized precision dosing to achieve that balance between efficacy and not overshooting with ejection fraction when you're doing that. And also minimal drug-drug interactions associated with aficamten as well. And in the Redwood phase 2 study with aficamten, it was shown to be safe and well-tolerated in lowered outflow gradients, leading to the pivotal phase 3 trial with aficamten called Sequoia HCM. Again, a very similar population in a way to the Explorer trial with mavacamten, symptomatic, functionally limited, obstructive HCM patients randomized for 24 weeks to aficamten or placebo for a primary endpoint in this study of an improvement in functional capacity as measured by peak VO2. I'm showing you the results of the primary endpoint here to Sequoia. You can see a significant increase in functional capacity with a 1.8 increase in peak VO2 with aficamten compared to no change in peak VO2 in those randomized to placebo. And again, to put that into kind of clinical context, that improvement in peak VO2, we consider in HCM an improvement in peak VO2 of one milliliter per kilogram to be clinically relevant. And so this improvement of almost 1.8 or 1.7 placebo corrected far exceeds that clinically meaningful change in functional capacity with aficamten. And again, what's driving that is the profound effect on outflow tract gradients. Again, a similar principle that we saw with mavacamten, seen here with aficamten, where you see very rapid, with aficamten, at least rapid reductions in gradients in blue here, both at rest on the left and with Valsalva on the right. And essentially, even by week 2, you're seeing with aficamten gradients that are lowered significantly, and certainly by steady state, week 8, you see almost near obliteration of gradients in the vast majority of patients that's maintained over the treatment period. Again, this washout period at the end of the study, this 4-week washout period from week 24 to week 28, where patients are taken off of aficamten, you can see the reversibility here, where then gradients go back to baseline. And again, when we're talking about safety with aficamten, here is that change in ejection fraction in those randomized to aficamten, with a change in the cohort that were randomized to aficamten, a decrease in EF of about 5%. But again, when we're looking at that barometer of EF of less than 5%, or less than 50%, I should say, by core lab analysis in Sequoia, it was 3.5% of patients on aficamten that EF of less than 50%, and about 4.9 by site read echocardiograms. Here are the distributions of those EFs, low EF events. Importantly, those on aficamten that had EFs of less than 50%, none of them had heart failure symptoms. None of them had to interrupt treatment. There was dose adjustments, but no need to stop aficamten. And again, in those that had low EF events, in which dose was adjusted at the next evaluation, the ejection fractions were all above 50% in those patients. No serious adverse events associated with aficamten in the Sequoia trial. And so what I want to do here for you, because I think it's helpful here, is to make a broad comparison based on the phase 3 trials between aficamten and mavacamten. Again, a couple things. Aficamten is not approved yet by the FDA. It's under investigation. So it's not approved by the FDA, under investigation. Okay, mavacamten is approved by the FDA for symptomatic obstructive HCM. And so what I'm doing here, again, it's hard. Let me just say it's challenging to make cross-trial comparisons between two drugs. Nevertheless, we may see a day soon in which both of these drugs are available. So I think there's some value in sort of understanding kind of how these two compare to each other, given though that these direct comparisons have limitations in what you can extrapolate with that. Nevertheless, if you look at low EF events, 3.5 to 4.9% for AFI, slightly more incidence of low EF with mavacamten in the phase 3 trials. No heart failure events associated with low EF with aficamten. A small number of patients with Mavi had an increase in heart failure related to low EF events. The need to temporarily discontinue drug, none in the Sequoia trial with AFI, and about 29 patients in the phase 3 trials with Mavi had to temporarily discontinue either because of low EF or other issues. Dose titration shorter with AFI, longer with MAVA. There are no known drug-drug interactions with aficamten, and there are some select ones with mavacamten. Again, AFI is under investigation, so we don't know if there is going to be a REMS program, and if so, how it will compare to what we have with mavacamten, because again, it's under investigation. Gradient reduction less than 50%. You can see the percentage there, slightly higher with mavacamten, but pretty similar. Peak VO2, again, slight advantage to aficamten in a greater enhancement in exercise capacity. If you look at symptoms by NOHA, pretty similar proportions, but slightly greater with mavacamten. And if you look at improvement in functional capacity as well as an improvement in symptoms, pretty similar between the two drugs, with a slightly greater proportion with aficamten achieving that clinical endpoint. Okay, I will turn it over to Greg.
All right, thanks, Marty. So we'll talk about outcomes optimization. And I'm going to pick up the pace a little bit because I know we're running a little behind. So which of the following interventions consistently augments exercise performance in obstructive HCM? Non-vasodilating beta blockers, ACE inhibitors, disopyramide, septal reduction therapy, or none of the above? All right, so 41% said septal reduction therapy. Second highest was beta blockers. So we'll get into the data, and then far fewer on ACE inhibitors and none of the above. So what do we know from objectively measured exercise capacity before and after intervention in patients with obstructive HCM? So I know Sarah showed some nice data from the very early stages of beta blockers, often focused on exercise time or angina. When we look at peak oxygen uptake, which was the focus of the studies that Marty just described, you can see that beta blockers really had a relatively neutral effect. Remember, they do impair chronotropic response to exercise. If we look at the cardiac myosin inhibitors, consistent benefit, as was just shown in peak VO2. And then if we look either by alcohol septal reduction or surgical myectomy, you can see consistent improvements in peak VO2 with these interventions. This is the Explorer trial, just a deeper dive into the exercise endpoints. And in brief, improvements in METs, exercise time, end-tidal CO2, and VEV-CO2 slope with mavacamten in the Explorer trial. In Sequoia, Marty just showed this data. We looked at peak VO2, and then we went on to look at additional metrics of exercise capacity measured throughout exercise beyond peak VO2 alone. And we specifically looked at a new integrated measure that incorporates both the VEV-CO2 slope, which is measured throughout exercise, and the peak VO2, which of course is a peak exercise parameter. And we created a Z-score because both of these measures are highly prognostic in HCM. And we said, what would happen to a composite equally weighted of VEV-CO2 and peak VO2 in patients who are receiving aficamten versus placebo? And you can see that this combined Z-score improved with aficamten relative to placebo in a highly statistically significant manner in the Sequoia trial. So complementary data to what Marty just presented. In terms of the responder analysis, you can see modest numbers needed to treat to achieve a large improvement, moderate improvement, or any improvement in peak VO2 relative to placebo with aficamten treatment. And then we further evaluated how does the change in peak VO2 relate to things like Kansas City Cardiomyopathy questionnaires, patient-reported quality of life score, New York Heart Association class, and you can see that those that experienced the greatest improvement in peak VO2, shown here along the x-axis, also experienced the greatest improvements in their Kansas City Cardiomyopathy scores, in their New York Heart Association class, and importantly, the improvements in peak VO2 were proportional to changes in LV outflow tract, both at rest and with Valsalva. But as I mentioned previously, it's not just about the outflow tract gradient. So it turns out an even stronger relationship was present between changes in NT-proBNP, perhaps a more global indicator of cardiac wall stress in HCM, and changes in peak VO2 in our patients, where you can see dramatic reductions in NT-proBNP in terms of change from baseline associated with dramatic improvements in peak VO2 in a subset of the patients in Sequoia. We also found that the cardiac troponin levels fell proportionate to improvements in peak VO2. And then this are just additional variables really mirroring what was seen in Explorer, but pretty much every single exercise variable that we looked at improved, both submaximum and maximum exercise capacity.
Okay, we're all starting to even out here a bit in this competition. Moving into round 3, we're going to be discussing some specific cases. So the first case is going to be that of a young person with symptomatic obstructive HCM. She's a 23-year-old woman with a family history of HCM that involves her paternal aunt and uncle. It is caused by a disease-causing NYBPC3 variant, and she's coming in for clinical screening evaluation. She was last evaluated a decade ago when she was 13 and had normal EKG and echocardiogram at that time. She has no chronic illnesses. She's not on any medications. She exercises 3 to 5 times a week using a walking, jogging kind of protocol and light weights. And notes that during stressful times, she has pounding in her chest and lightheadedness. And also that in the past 6 months, she's been experiencing chest pressure when she's jogging or climbing a couple of flights of stairs. She feels fatigue for several hours after each of her exercise sessions, and that's not been her norm previously. Here's her echocardiogram. It's a parasternal long view, where we're looking at the left atrium, mitral valve, left ventricle into the outflow tract, the aortic valve, and into the aorta. The septum, of course, is in the middle, separating the right and the left ventricles. And you can see what the measurements by the sonographer had been. The sonographer measured the basal septum at 13 millimeters and the posterior wall at 8 millimeters. Here's the parasternal short axis images, and you can actually see that the septum in the basal infraseptal portion of it actually is a little bit thicker than what we saw in the parasternal long, measuring 19 millimeters. Here's her 4-chamber view with and then her 3-chamber view with color. You can see that there is a little bit of turbulent flow around that outflow and around that basal septum into the outflow tract. Here are her gradients in the 3-chamber view, both at rest on the left and with Valsalva on the right. So you can see that she really has no obstruction at base, and the gradient is about 20 millimeters of mercury with Valsalva. Because we had detected that she had that basal infraseptal hypertrophy and the symptoms that she had, we actually were quite suspicious that she had probably more significant outflow obstruction with activity than what we were able to bring out with just Valsalva. So we actually put her on the treadmill. We did an exercise CPET. She did 8 minutes of exercise on a ramp 11 protocol. She stopped because she was tired. She had a normal blood pressure response to exercise and a pretty normal heart rate response as well, achieving 92% of her max predicted heart rate. She gave good effort and hit anaerobic threshold. Her peak respiratory exchange ratio was 1.07, so you can feel pretty confident that the study quality is good. And her peak VO2 was 26.6 milliliters per kilogram per minute, which is 100% of what's predicted for her age and gender. She had normal onset, anaerobic threshold, and normal VEV-CO2 slope through exercise. And you can see that she develops actually quite significant obstruction post-exercise with a gradient of 70 millimeters of mercury. We actually started her on metoprolol succinate 25 milligrams a day to try to tamp down this obstruction and the related symptoms, and she had worsening fatigue with that. So then we replaced that metoprolol succinate with verapamil 120 milligrams a day, and which she was able to better tolerate from the perspective of fatigue. She didn't have that side effect with it, and then kind of gradually increased the dose over a couple of months to 360 milligrams a day, with which she actually had an improvement in her symptoms. And she maintained that dose for about 2 years until we saw her again as part of her routine care. And she was noting that again, she was having this exertional chest tightness and pressure. And we put her we repeated her echo and found that her resting gradient on 360 milligrams of verapamil a day was 44 millimeters of mercury, and with Valsalva topped up to 82 millimeters of mercury. So the question is, what do we do next? Should we add disopyramide? Should we refer her for surgical myectomy? Consider her for mavacamten? Refer her for alcohol septal ablation? Or implant an ICD in order to provide pacing to relieve that outflow obstruction. Okay, so 71% of you decided that she should be considered for mavacamten, and I can completely understand why you would say that. Only 6% actually did what I did, which was referring her for surgical myectomy. And I think just to have a discussion about, who is an appropriate candidate for long-term medication like mavacamten. Things that I didn't include in the information I provided to you is that she had just recently actually gotten married and would like to pursue a pregnancy. Mavacamten is contraindicated in a pregnancy, and I would caution everybody when they're thinking about cardiac myosin inhibitors in young people in particular. I think it's a real challenge to have somebody, placed on mavacamten for treatment of their symptomatic obstructive HCM, get that under control, and then to have to pull that off when they are pregnant because you can't be on mavacamten during a pregnancy, and then have to deal with the consequences of significant outflow obstruction during the pregnancy, and very specifically in developing a birth plan. So we did not choose mavacamten specifically because of that. She is pretty young and would not likely be a good candidate for alcohol septal ablation because of her age, and it's really contraindicated or discouraged, I should say, in people who are younger than 40. I didn't choose disopyramide because, again, it's not a medication that we would necessarily want for her to be on through a pregnancy, and it's already been shown that RV pacing does not adequately relieve outflow obstruction in previous studies. So we referred her for surgical myectomy. She had a fantastic outcome and recovered really quite well, and moved on to planning a pregnancy about 6 months after surgery, and now has a healthy baby and had an uncomplicated pregnancy and delivery. I'm going to have Dr. Marin take over to discuss his case of an older patient with comorbid issues.
Okay, thanks, Sarah. That was a great case. And so, yeah, so we're going to talk about a 72-year-old woman, obese, history of asthma, sleep apnea, osteoarthritis, hyperlipidemia, spinal stenosis, and lung cancer, status post-surgery for that. Worsening heart failure in that setting due to obstructive HCM. So she sort of progressed to class 3, poorly tolerant of both beta blockers and diltiazem, poorly tolerated, and they weren't very effective either, with a baseline 12-lead ECG that shows normal sinus rhythm with a left bundle branch block pattern. So here's the imaging, and you can see with the long axis echo imaging here on the left, the 2D. I'll tell you that the wall thickness was minimal, 16 millimeters, predominantly confined to the basal septum. You can see at rest, there's systolic anterior motion of the mitral valve, but no contact with the septum. And in the color, there's some increased turbulence by color through the outflow without much mitral regurgitation. And in corresponding continuous wave Doppler profile through the outflow tract shows a 2 meter per second velocity, consistent here with non-obstructive physiology. Okay. And so the first point I want to make, and this is a huge, in my view, a huge pearl, is that when you've got patients with HCM who are symptomatic with limiting dyspnea, decreased exercise tolerance, et cetera, and they've got no evidence of outflow obstruction at rest or even with Valsalva maneuver, you've got to move on in that situation, and you've got to provoke that patient to determine if they've got a physiologic provocable outflow tract gradient, because the demonstration of an outflow gradient will change the management of that patient. Okay, opening up treatment options that are not available to symptomatic non-obstructive patients. Okay. Sorry. And so, let me go back. And so that's what we did here. It's a symptom-limited Bruce protocol, upright. Patients get done. They lay supine quickly, hopefully, with imaging done. Again, focused on the outflow tract. At least our protocol would focus first on the apical 3-chamber to demonstrate whether with physiologic exercise, there is the development of a gradient from mitral valve septal contact, which there was in this case here. You can see that very well in the still image in mid-systole during the first few minutes after exercise, corresponding to, by continuous wave Doppler, an outflow gradient of close to 100 millimeters of mercury that you wouldn't have known about if you hadn't exercised, because as I said, this patient had no gradient at rest and no gradient with Valsalva. Okay. About half the patients, by the way, with no gradient with Valsalva will have an exercise-induced gradient of 50 millimeters of mercury or more. Again, emphasizing the importance of exercise as a provocative method to determine latent outflow gradients. Here is the kind of complementary imaging with CMR that was done as well, helping to really define wall thickness here in this patient as well, in this apical 3-chamber of the clearly mitral valve septal contact that you can see at rest during the MRI. Actually, again, gradients are really dynamic. So sometimes you may not see it on the echo, different time point the MRI is done, different loading conditions, you can actually see mitral valve septal contact. We usually don't quantify gradients with MRI. It's hard to do that. That's in the domain of echocardiography. The other thing to point out here again is that basal hypertrophy is minimal here, just 16 millimeters with relatively normal wall thicknesses throughout the remainder of the LV chamber. Okay, so you've got, to summarize, older woman with a lot of medical comorbidities, with a diagnosis of HCM with a wall thickness that is consistent with a minimal hypertrophy of 16 millimeters, normal systolic function, mild left atrial diameter increase, SAM at rest, no gradient, but with exercise, close to 100 millimeters of mercury. And also with exercise, I forgot to point out, there was no change in the minimal mitral regurgitation. So what's the next step then in management in this patient who's class 3 obstructive HCM, not tolerant of beta blocker or calcium channel blocker therapy? Surgical myectomy, alcohol septal ablation, Norpace or disopyramide, or consideration for cardiac myosin inhibitor. Okay, good. Excellent. So let's just talk through this before moving on to Greg's case. So yeah, I mean, surgical myectomy, you heard Sarah present a great case of when surgical myectomy, would be a particular value. Here in this patient, too many comorbidities, advanced age, you're looking at an increase in surgical risk here that probably is certainly increased, but probably close to prohibitive here. And so that's not a great option. Alcohol septal ablation, a catheter-based approach to relief of outflow gradients, not a great option here because of the minimal septal hypertrophy of only 16 millimeters. I think as Sarah mentioned, when you've got minimal hypertrophy, it's not that it's contraindicated, but that it's often suboptimal outcomes when you've got minimal hypertrophy, and also increases the risk of the procedure as well. So alcohol ablation, and as also mentioned, this patient had a left bundle branch block at baseline. Alcohol septal ablation will give you at least the majority of the time a right bundle branch block. So you would be almost assuredly, or at least close to 80% or higher chance of complete heart block with alcohol septal ablation. That dimmed enthusiasm even more for this procedure for the patient, and that's why it was not a great option. Disopyramide, not a great option here either, particularly given the baseline left bundle branch block, increased risk with disopyramide in that setting for more advanced heart block. And also, this patient's got class 3. You're really looking for a more definitive relief of outflow gradients. And I think suboptimal result probably if you use disopyramide. And also, you would be taking on increased risk with that left bundle branch block of conduction problems. And that really points to cardiac myosin inhibitor being really helpful here as your primary choice. That was our choice for this patient. And again, just to follow up, you can see the efficacy here. The myosin inhibitor kind of modulating that ejection fraction, taking it down several points here to get rid of the outflow tract obstruction. This is actually in the post-exercise state and showing you again, no outflow gradients, mild SAM, but no gradient. And this patient achieved a lot of benefit from myosin inhibitor with substantial relief in gradients. Very happy patient with that treatment. Okay. Move on to Greg.
Okay, thanks, Marty. This is going to be our final case. So we're going to talk about non-obstructive HCM evolving into advanced disease, which we've heard a little bit about. I'm going to emphasize that. So this is a case of a 62-year-old gentleman, long-standing non-obstructive HCM, initially diagnosed after he experienced syncope with evidence of left ventricular thickening up to about 18 millimeters at the mid-ventricular level at the time of his initial diagnosis. He struggled with atrial fibrillation, has had multiple cardioversions, has been on amiodarone, sotalol, and had an AF ablation. But when I met him 1 year of progressive fatigue, he was avoiding strenuous activity on account of progressive dyspnea and exertion, and you can see his ejection fraction fallen to 26% with some LV dilation. His laboratory results were notable for mild elevations in his BUN and creatinine, a reduction in his sodium level. His hemoglobin A1C was mildly elevated. And you can see at the time of right heart catheterization, he had relatively modest right atrial pressure. His pulmonary capillary wedge pressure was elevated at 18 millimeters of mercury, and his mean PA pressure was elevated at 26. His cardiac index was significantly depressed at 1.8, with a mixed venous oxygen saturation of 60.7% and evident hypertrophy on his ECG. So what's the most appropriate next step in the care of this patient? Up titration of his beta blocker, referral for septal reduction, surgery, referral for cardiac resynchronization therapy, performance of a cardiac MRI, or performance of a cardiopulmonary exercise test. Okay, so we've got an admixture of results here. And this is a patient that has a very low ejection fraction with a cardiac index of 1.8. So he is unlikely to tolerate up titration of beta blockade. And we heard that there was a mid-septal, relatively modest increase in septal thickness. And so he was not a particularly suitable candidate for septal reduction therapy. His QRS complex was not particularly wide, hence cardiac resynchronization therapy agreed to have a minimum role here in terms of alleviating his LV systolic dysfunction that he developed. And you remember, he's basically a non-obstructive patient as well. And then certainly not unreasonable to perform a cardiac MRI, but the correct answer in this case is to perform a cardiopulmonary exercise test as is part of guideline recommendations for patients with non-obstructive HCM who are developing advanced symptoms of heart failure, which was certainly the case with this patient with his progressive dyspnea exertion and his low cardiac index. So we performed the cardiopulmonary exercise test on this patient. These are done with a 3-minute period of unloaded exercise, followed by an incremental ramp, in this case, a 10 watt per minute ramp protocol. And unfortunately, this gentleman was only able to exercise for 4 minutes of incremental exercise, so 7 minutes total, to 40 watts. His peak VO2 only got to 8.6 milliliters per kilogram per minute, despite a respiratory exchange ratio that was well above 1.0, indicating a maximum volitional effort. His peak heart rate actually got to 138 beats per minute. He had a slow heart rate recovery, and you can see a very modest, barely any augmentation in systolic blood pressure with exercise, an early ventilatory anaerobic threshold, a blunted peak O2 pulse, which is the product of stroke volume and peripheral oxygen extraction, reduced aerobic efficiency in terms of his VO2 work relationship, and a steep VE/VCO2 slope of 49 in terms of the ventilatory inefficiency in this case. So lots of high-risk features in this case. If we look at this diagram of thinking about the application of cardiopulmonary exercise testing to advanced therapy selection for patients, whether they have HCM with systolic dysfunction or more traditional forms of left ventricular systolic dysfunction. We know that if you exercise somebody and they have a reduction in peak oxygen uptake, in this case, his peak VO2 was less than 10 mLs per kilo per minute, which was far below 50% of predicted. He had failure to augment his systolic blood pressure with exercise, which was well below 120 millimeters of mercury. So there's oxygen uptake patterns, there's hemodynamic patterns in terms of blood pressure, heart rate, and then there's the efficiency and stability of ventilation. In this case, the VE/VCO2 slope was 49, well in excess of 36. And if we take any of these high-risk features when we're considering somebody with advanced heart failure, we know that any of these features confer a greater than 20% one-year mortality in these patients. We also know that heart transplantation here in the US is associated with a greater than 90% one-year survival, in some programs, including ours, greater than 95%. And so we would be doing this patient a disservice if we weren't considering him for advanced therapies such as heart transplantation. Conversely, if you have a relatively preserved peak VO2, efficient ventilation, lack of oscillatory ventilation, these patients generally do quite well. So this patient had all of these high-risk features, and therefore we proceeded to list him for heart transplantation. He actually underwent heart transplantation 15 days after the cardiopulmonary exercise test that I just showed, and he's currently post-transplant and doing very well.
Okay, so the Heartbeat Heroes won the challenge tonight. We appreciate all of the time that you all have spent listening to us and kind of taking all this information in. We have a few minutes to address some questions, and then anything else that anybody else wants to ask or that we don't get to address in the next 6 minutes left in the session, you can join us in the what's it called? The backstage pass, that's what it's called, and ask your questions then. So somebody had brought up a good point, and I think this refers to Marty's case, that the patient that he presented had spinal stenosis, and so did you make sure to check for ATTR? And I just wanted to take a moment to say, like, that's actually a great point to raise. HCM is a notorious mimicker of other diseases, and I've seen patients who've been diagnosed with HCM, but what they really have is Fabry, or diagnosed with HCM, but what they really have is cardiac amyloidosis. We've all seen these situations, and which are actually treated quite differently than HCM, and have disease-specific therapies that are very different than the disease-specific therapies that we now have for HCM. And so it's a good thing to think about when you're seeing patients with wall thickening or cardiac, like concentric remodeling, where there's increased LV mass, but without necessarily wall thickening, to think about what the entire differential is for that scenario, and not all increased septal or other cardiac wall thickness is equal to having hypertrophic cardiomyopathy. Along those lines, a question was asked, what is asymmetric hypertrophic cardiomyopathy? And Marty, I don't know if you'd like to take that one on.
Yeah, sure. So, so what that's referring to is a description of the pattern of increase in wall thickness that we see with hypertrophic cardiomyopathy. In almost all cases with HCM, that pattern ends up to be asymmetric, which means that there is greater increase in the wall thickness in one portion of the LV chamber, typically the septum, than the posterior lateral wall. And therefore, if it's thicker in the septum than the lateral wall, then it obviously will kind of give you an asymmetric shape to the LV chamber. A very small percentage of patients will have with HCM concentric, which means that the wall thickness is pretty similar, within 2 millimeters wall thickness in the septum versus the posterior lateral wall. But again, that's very much the exception. Very few have that. The vast majority, it's asymmetric.
Awesome. Another question that was asked, and we'll just make this our last one because I think that the answer may be a little longer. Greg, was what heart failure GDMT or guideline-directed medical therapy is contraindicated in HCM? I think maybe for simplicity, we should talk about it in terms of like obstructive HCM versus non-obstructive HCM, and maybe you can just address if there are any GDMT that are contraindicated for non-obstructive HCM and then for obstructive HCM.
Yeah, no, thanks for the question. I mean, I think part of this is where you, when you're meeting a given patient and at what stage of their disease they're at. We've heard a lot about, cardiac myosin inhibition tonight in patients who have very vigorous, oftentimes hyperdynamic hearts with supernormal ejection fractions. And then, at that final case that I presented was a patient who, had overt LV systolic dysfunction, and we were trying to rescue the heart from advanced heart failure. So I think we have to be careful about kind of a one-size-fits-all approach. We heard the data supporting use of beta blockade tonight, and perhaps that one is a bit easier in terms of it being appropriate throughout stages of HCM treatment. When we get into end-stage disease, if there's hemodynamic compromise in any form of heart failure, such as the case that I showed with a cardiac index well below 2 and threatened end organ underperfusion, then sometimes you need to pull back on a beta blocker, certainly if a patient is presenting in a state of shock. So the disease-specific therapies differ in HCM than they do in other forms of cardiomyopathy that can culminate in advanced heart failure. So, we don't think about kind of 4-drug GDMT the same way in HCM as we think about it in, say, a patient that has an idiopathic dilated cardiomyopathy, where there's a very strong evidence basis for SGLT2 inhibitors and ACE inhibitors or ARBs or Entresto. I think we have to be careful with drugs such as a drug like Entresto, where you have potent vasodilatory effects of sacubitril, and giving it to a patient that has evident outflow tract obstruction.
Very excellent points, and also just a point to remember that when patients are complaining about exertional fatigue and a lack of energy, it may be high dose beta blockers that are the cause of those symptoms. And I find myself often actually weaning down doses of beta blockers and calcium channel blockers and then reassessing to see how patients are feeling. And sometimes when PPO2s are significantly suppressed, I'm not sure if it's, the 400 milligrams of metoprolol a day or not. I'll peel that off and repeat the CPAP. So thank you for bringing that to our attention as well, Greg. Well, this has been a great evening. Thank you so much to all of you for spending time with us. We will meet you in the backstage pass if you would like to ask any further questions. Have a great evening, happy holidays, and a very happy and healthy New Year to all of you.